Go ahead and get started. Everybody can continue eating and enjoying, but we'll get started with the talk. So we're honored to have Dr. Dan Lucey here. He's kind of a regular here at One Health Academy, and he teaches global infectious diseases at Georgetown University Medical Center. And has worked as an attending physician and researcher at NIH, chief of infectious diseases for Washington Hospital Center. So he's done quite a few things, and he's went to Ebola twice in the past, or went to West Africa twice to work on Ebola. So we'll go ahead and get started.
Thanks. Thanks, everybody. So it's a real honor and a privilege to be here tonight. I'm really looking forward to talking with you and answering questions. I'll try to keep the presentation to 30 minutes. And there'll be a lot of slides, especially after the first few introductory slides, a lot of pictures, I should say, both from Freetown, Sierra Leone, where I went in August, and then from Monrovia, Liberia, when I went October to November. So it was 9 weeks altogether. And when I came back in end of August, beginning of September to DC, there was no quarantine, which was just great with me. And so I was able to go to the university every day and help organize some symposium on Ebola and live normal life. But then when I was in Monrovia on October 3rd, November 14th, I was informed that by my colleagues at the DC Department of Health and at Georgetown University that could not come back onto the university, couldn't take public transport, and because I had direct contact with patients pretty much every day for almost 6 weeks in Monrovia. But that's in the past now. Although spring break for the students is coming up, March 4th. I'm adding on a little bit of time. March 4th to the 16th, so I plan to go back for those 2 weeks to West Africa. Although not for patient care, so I won't have to be quarantined when I come back. All right, so I've titled this Emerging Zoonotic Diseases, What is Past-as-Prologue, particularly for this audience, so One Health Academy. And again, it's an honor to be here to talk with you. Obviously, Ebola is a zoonotic disease, as many emerging infectious diseases are, MERS, SARS, avian flu, so many that we know. And I think that one point that I want to try and make, and so I put it on to maybe 2 slides, is that there's a lot of the talk now, important talk about getting to 0 cases of Ebola, but what's implied is 0 human cases. But I think before we can realistically hope to ever stop having more human outbreaks in the human, our species of Ebola, of which there's been 24 or 25 since 1976, all in Africa. Well, this is the first one in West Africa. We need to be able to control the disease or eradicate disease, if that's not too unrealistic of a goal, in the non-human animal species. I'd like to dedicate the talk to Dr. Martin Salia and to other colleagues, healthcare colleagues in West Africa fighting against Ebola. Dr. Salia is one of more than 830 health workers in West Africa infected with the Ebola virus since last year. And this is the reference is yesterday's World Health Organization update. They do a weekly update, as you probably know, every Wednesday afternoon. Oh, it's okay, ma'am. More food. Yes. Okay. Okay. Thank you, Mabel. Thank you, Mabel. So the WHO every Wednesday afternoon puts out an update on Ebola, and somewhere 2/3 of the way through the document, it gives the update on the number of healthcare workers infected with Ebola and the number of who have died. So yesterday is a little bit over 830, including the 3 main countries where the outbreak is: Guinea, Sierra Leone, and Liberia, but also Nigeria and Mali. Dr. Martin Salia was a surgeon in Sierra Leone. He went to school in Connaught in the east, where a large part of the outbreak was early on in Sierra Leone, and subsequently in Freetown, the capital. I worked at Connaught Hospital, which is where I worked in August. We didn't actually meet one another, but tragically, he's one of the many healthcare workers who was infected with the virus, and one of approximately 500 who have died. 500 died, mostly nurses, of course. And he had a direct link with Georgetown University, and there's a memorial service early December 8th, which his wife and his 2 sons who live in Maryland were present for. So again, to emphasize what I said, there will be more epidemics in humans of Ebola in West Africa, in my opinion, and I'm certain about that. Unfortunately, there will be more epidemics unless we can get to zero cases in both human and animal species. In other words, implement the One Health paradigm. This is a picture of Dr. Celia, born in 1970. In this slide, I'd like to very, very briefly cover the past 33 years of my life. So 1982, and I first went from the smallest medical school in America in rural New Hampshire to San Francisco General Hospital and University of California, San Francisco in June of 1982, which was the beginning of the horrendous pandemic that we're all familiar with, zoonotic disease, HIV, AIDS. Basically worked for pretty much 20 years in different places at UCSF, at Harvard, at the Department of Defense, U.S. Public Health Service, and then at Washington Hospital Center here in D.C. But as other new diseases, infectious diseases emerged, I basically was attracted to trying to learn as much as possible, as fast as possible about them, in part because of what happened in 82, 83, 84, 85 in San Francisco with AIDS, and then in Boston, similarly, the outbreak of AIDS was the pandemic of AIDS was a few years behind in Boston compared to San Francisco and New York. So by going there in 85 to Boston, it reminded me of San Francisco in 82. So I've tried to learn as much as I can about new infectious diseases as they emerge around the world. And you can see a lot of these are zoonotic diseases. So West Nile virus, as you know, came to New York in the summer of 99. Anthrax came to where we are in 2001, inhalational anthrax, intentional dissemination. There are the issues about smallpox and smallpox vaccination. I was involved in. I was very proud to be the first civilian vaccinated, except for the president in D.C. But that's not really saying that much because there were only 4 of us who volunteered. 2 from the Department of Health, including the director at the time, and chief medical officer, and then one other person. In fact, basically all of us had some military background. So I filled out my paperwork faster than everybody else. Ran to the head of the line. I said, I want to be vaccinated. But thank God there's been no smallpox in the world in a long time. And then there's outbreak of monkeypox here. First time I'd been out of Africa in 2003. SARS, of course, in 2003. I went to Hong Kong and Guangzhou, and then was able to work in the SARS hospital in Toronto in June of 2003. And then the avian flu outbreaks, so I went to various places like Indonesia and Vietnam and Thailand and Cambodia, and then Egypt. And I've gone back almost every year to Egypt since then. And then the pandemic flu started, as we all know, in 2009 and 10, and Egypt invited me back because of pandemic flu, having been there a number of times since 2006 for H5N1. And then MERS, Middle East Respiratory Syndrome, occurred and wasn't recognized initially in Zarqa, Jordan in April of 2012, but subsequently in Saudi Arabia. And I spent about 6 months there in the Middle East and a variety of countries in 2013. And then avian flu, the newest one, H7N9, emerged about 23 months ago in eastern China. And then finally Ebola, which we know now probably started in December, perhaps earlier, of 2013, but really wasn't identified and reported on the WHO website until March 23rd of 2014. So my own personal opinion, I'll say, is that I think we have a long way to go to get to zero of human cases. Even in Liberia, you'll hear about some event that's occurred in the past few days in Liberia, more human cases. And we haven't gotten to zero in Liberia, but it's come way, way, way down from when it was the epicenter in August and September of 2014. And patients were being turned away from the Ebola treatment units because there wasn't room for them, and it wasn't room for them. What does that mean? I mean, the hospital I worked at, Doctors Without Borders, called Médecins Sans Frontières, or MSF. When I got there October 3rd, it consisted of 10 tents for laboratory confirmed patients, and a mattress on the floor of the tent. And the tents I was involved with helping to take care of the patients, there were 4 tents, 15 mattresses in each tent. So that was the hospital. No laboratory tests possible, none, zero, nada. No potassium, no sodium measurements, no blood counts, no hemoglobin, no white blood cell count, no kidney function, no liver function, none. But that was early October, and in August, September, things were much, much worse, to where there weren't enough mattresses in the tents, and healthcare providers and patients had to be turned away at the gate. Even though it was known that they had Ebola, And it was known that they would most likely die, even more likely die than if they were admitted to the hospital, probably a lot more likely. And before they die, they could transmit the virus to others in the community, their family, or other people. And after they die, as you all know, the virus is still infectious in the corpse for some number of days afterwards. So Ebola's not gone. In my view, it may not be gone in 2015. I hope it is. People are talking about it. People, important people, smarter people with more authority than me, for example, World Health Organization, and that's wonderful. I think that's a very important goal to have, to get to zero Ebola human cases in 2015. I hope it doesn't become endemic instead, which is the other end of the spectrum. And then for me, I'm always thinking, and some of my students are here from Georgetown because normally we have a class tonight. So I said it's mandatory formation to be here at the One Health Academy, and others promised me they're listening in on the webinar. So I told them there'll be a test next week. So I'm always thinking about what's next, not because what's still here doesn't matter. It does. It matters a lot. And I'm very excited to be able to go on spring break back to West Africa in early March. But there's something else over the horizon that we just don't know about. And there's some people here that I think are involved with global biosurveillance for various agencies, or people like me who are just curious and wake up every morning and look at ProMed, and then at noon look at ProMed, and at night look at ProMed, and call friends and Skype with people in West Africa and in China and elsewhere around the world. So what's next? Because you need to know what's coming so you can learn about it and help prevent and respond to it when it arrives. Okay, so the outbreak started in the confluence of 3 countries. And Guinea is first reported. The Guinea is here, and it wraps around and borders Liberia and Sierra Leone, the red areas where it first was reported, 23 March, affected districts. So no surprise, really, that the virus, people being infected with the virus, were soon present and traveling on across the border of Guinea into Sierra Leone and into Liberia. In fact, the outbreak had started in early December, to the best of our knowledge, but it just wasn't recognized. So one thing that really caught my attention, March 23rd, and then later in March, and then early April, meaning 3rd of April, WHO put out several updates. They call it disease outbreak news. And you can see here that already, I'm almost certain it was the end of March, but what I'm showing here is proof positive. The 3rd of April, the statement by WHO is that the virus is already in Conakry, which is the capital of Guinea, right? So what? Well, and then by April 7th, it was reported already to be in the capital of Liberia, Monrovia. This is, again, a WHO map. Here's Conakry, there's 20 cases, 6 deaths. Here's Monrovia, red means areas with confirmed cases. So this is the very beginning of April. And the virus is in 2 capital cities. And in my view, that's very, very important to me. It's a huge red flag. It's a huge, loud drum that's being beaten a lot over and over during the nighttime, during the daytime. Why? Because the virus had never been in capital cities before. 4 outbreaks since 1976 in Africa, never in capital cities. And rarely in cities. And so I'd say that matters for a lot of reasons, and to focus on 1 or 2 of them. One is that the virus in the city makes it, in my opinion, probably more difficult to control. You do contact tracing to isolate people who are sick, to quarantine people that are exposed, which worked always before with the rural outbreaks in DRC, former Zaire, in Gabon, in Uganda, in Sudan, and elsewhere. But it's going to be much harder to contact trace and effectively and rapidly isolate people who are sick and quarantine people that are exposed in cities. And maybe it's less difficult in U.S. cities, but it's still not easy. Maybe, but it's hard in cities the parts of the West African capitals that I've seen. So to me, this is a big red flag. It means we have to do a lot more and faster than we've ever done before. We, meaning the international community, with our colleagues in the 3 impacted countries. And then soon after, as you know, traveler from Liberia went to Nigeria, and a traveler from Nigeria, a doctor from one place went to another, a patient did, and then to Port Harcourt from Lagos, and a doctor got infected in Nigeria, and then several patients were found in Mali. So for me, this was a big red flag. So, basically I just sitting home and, watch CNN and BBC and talk to students, and that's that. But this is a big red flag. So you can talk, which I like to do, obviously, but really, at this late point in my life, like you're going to take some action or not. Okay, but I'm not, Director General of World Health Organization or anybody else really. So what can you do? Well, some colleagues who are emergency medicine doctors in Minnesota and Virginia said to me, you're an infectious disease guy. You always talking. Why don't you write some frequently asked questions about Ebola? Because we don't know what Ebola is, but it sounds kind of scary. As it, just basic questions, so they could disseminate to people in their hospitals. And then, unbeknownst to me, so 8th of April, so I started drafting them. I sent them to them. They comments, and I'm just showing the first one or two, but I don't know, maybe 15 questions and answers put together. But basically, I just want to show that I put in the fact that the virus was already in 20 patients in the capital of Guinea, Conakry, and this is proof that I didn't change anything because I misspelled Conakry. The R and the K I transposed. And so I got a bunch of letters, emails back from people because what my good friends, the emergency medicine doctors, did, they sent this frequently asked questions without asking me, but that's okay, to what's called the Health and Human Services Hospital Preparedness Program, which I wasn't intimately knowledgeable about. I didn't know anything about it before this, but it got sent out to many hospitals I think in every state. And I got a whole 5 or 6 emails from people I don't know from different states, from Oregon, from Texas, saying, you misspelled the capital of Guinea. Well, in a way, I was glad because it means they read it. They read it. April. I think it went out April 15th because we did some drafts and anyway. So my point is, so that's. But and I also sent out some emails July 30th and then September 10th to everybody. I had an email address for saying we should be preparing in American hospitals and public health departments a comprehensive, standardized Ebola personal protective equipment protocol. July 30th, September 10th. I don't think that much was done. Very much was done prior to Mr. Duncan being admitted to the hospital in Dallas around September 26th. So finally, it was August 8th that the World Health Organization Director General Margaret Chan declared that Ebola was a public health emergency of international concern, PHEIC, which has specific ramifications. It requires certain measures to be put forward and then reviewed every couple months. But many people have asked why was there no earlier meeting of this advisory committee to advise the Director General whether or not the Ebola outbreak in West Africa should be considered an international public health emergency of international concern. I think it's a legitimate question, especially because Ebola was found in capital cities from the beginning, which had never been found before. So, so the other reason, why should we care about capital cities being involved? I don't really think there is any other better reason. But for some of us, perhaps somewhere in the world, not in this room, nobody in this room and no one on the webinar, I'm sure, but you could say Ebola's over there. It's really terrible for the people over there, but it's not going to affect me. It never has before since 1976. But it's in the capital cities now. What's in capital cities? International airports. So sooner or later, there's going to be a traveler that gets off the plane, and maybe in a country that we know, maybe in one nearby, maybe in one far away, maybe in all of them. And you have the pattern. It happened with MERS last May. 2 healthcare workers come from Saudi Arabia to the United States, and then they become sick with Middle East respiratory syndrome. Travelers went to many places with severe acute respiratory syndrome, SARS, in 2003. It's wholly, entirely predictable. So with some colleagues, Larry Gustin and Alexandra Phelan from the law school at Georgetown, we wrote this article. They appeared online. We wrote it the 8th, the 9th, actually before the 5th, 6th, 7th, 8th, anticipating the declaration of Ebola as a public health emergency of international concern. And then thanks to Dr. Gustin and his connections at the Journal of the American Medical Association, JAMA, they worked all weekend. It was published on Monday, the 11th of August online. And I was very happy to hear that because on the 10th, I was on the plane to go to Sierra Leone. I was so happy. Finally, it's not just talk. Go and understand and see, work with colleagues from other countries, if that's possible. That's what I always try to do, and sometimes it's more possible than other times, or less possible than other times. And so I was fortunate to be able to arrive in Freetown. Now, this is the time when the outbreak was not in Freetown, which is on the Atlantic Ocean on the western side of Sierra Leone, which is now the epicenter of the epidemic in West Africa, but it was in the eastern part of Sierra Leone, a place called Kenema and Kailoun and elsewhere. So there was this is mid-August, there was no treatment center for Ebola. patients with Ebola. No treatment center in the whole western part of the country, including Freetown, the capital. And where I worked was a testing center. People came there to get the test done. But it was an inpatient facility at a big hospital called Connaught that had been a little small part of the emergency medicine department had been devoted to an Ebola testing unit. That's what I call it. It was called other things, isolation unit, but the patients weren't isolated. They're all, one was right next to the other, And there were 13 beds, but there was no isolation. And everybody's really sick. You come there because you have vomiting, diarrhea, fever, but it could be because you have typhoid, could be because you have Shigella, could be because you have malaria, or it could be because you have Ebola or something else. So I was very fortunate to be able to work there, in part because there was hardly anybody else that, how should I say it? There's hardly anybody else working there. The leading Sierra Leonean doctor from the hospital, in terms of, he was the number one on the flow chart that was still on the wall in charge of the Ebola response, leading number one Sierra Leonean doctor. Yeah, died of Ebola. Came to the Ebola unit one time. But a very important point I want to convey is that it's really hard, as I've already implied, it's really hard to tell Ebola without the lab test from other much more common diseases like malaria or typhoid. So doctors and nurses take care of lots of patients. The Ebola unit was one tiny part of this huge referral hospital, the biggest one in the western part of the country, Sierra Leone. So you don't wear Ebola-specific personal protective equipment when you're not taking care of patients suspected of having Ebola. So you might take care of someone that you think has a complicated delivery of a child or someone who has malaria, but they have Ebola. And so you're not wearing the appropriate or the necessary personal protective equipment and you get infected. But because the number one doctor in the hospital for the Ebola response got infected and died, it had a chilling effect on everyone else. The younger people, less experienced people, they said, well, if it happened to him, it's likely it'll happen to me. So it was a situation where I was able to work there because there was a great need. Basically, when I went there was one Spanish doctor working there. And you never, ever, ever work alone. Really, never do that. It's so dangerous. I don't know how she's done it, but she did. And then one doctor from the UK, 27 years old, who got called back to London. And so the Spanish doctor was working by herself, and then he came back. And now it's improved a lot. The UK has really done a great job in Sierra Leone now. So again, just to emphasize that in mid-August when I was there, in Freetown, there were many hospitals closed because of the fear of Ebola. And so what does that mean? So there's one big pediatric hospital in Sierra Leone, and it's in Freetown. August 18th, it closed because they had one child, 4 years old, who had Ebola, and was in the hospital in the emergency medicine department area for a day or two. Couldn't figure out what the child had. The parents swore that there had been no epidemiological link to exposure to anybody with Ebola, but they weren't telling the truth. They had been at a burial for a patient who had Ebola, and there had been contact with body fluids. As a result of the child being recognized, was transferred to Connaught Hospital to be tested. And again, it's not a place for children. It's really not a place for children. And neither the Spanish doctor, the UK doctor, or myself are pediatricians. And it's not a place for children. So child tested positive. As a result, the hospital closed down. When the results came back, within 24 hours, the hospital closed down. It's the one big hospital for children in the country. Where do all those sick children go that are in there? You got to be really sick to get in American hospitals. You got to be, I think, much sicker to get into hospital in Freetown. So where all those children with cerebral malaria go, and what do you think is going to happen to them when they have to leave the hospital in 24 hours? So I would say there's been many more. I can't show you any numbers or proof. I haven't seen in publications, but everyone talked about it. Everybody says, yeah, you see it, but I can't offer you the numbers because I haven't seen them myself published. But I would say that many more people have died due to non-Ebola diseases, both infectious and non-infectious, complications of diabetes, complications of pregnancy or delivery, but indirectly due to Ebola, because healthcare clinics, hospitals, access to medications, access to healthcare, came close to terminating because of Ebola, the fear of Ebola, which is, it was frightening in this country, right? I wasn't here in October, but I heard about it. But it's real. It's 830 healthcare workers infected with Ebola in West Africa. And the PPE is not good in some places, or at least back in August. The one other thing I want to emphasize is that there's no treatment center, but also there's no laboratory that could perform the diagnostic test, the PCR and the blood for the virus in Freetown in mid-August. So we're a testing center. So what am I standing up here talking about with testing center? How could you test? Draw the blood, call for a driver and a vehicle. That often the driver would say, "We don't have any petrol, we don't have any gas. You know, they ask the Spanish doctor to give some money for the gas." Then they drive 4 or 5 hours to the east to Connaught, which was a big outbreak center where they had the laboratory. Well, the result of that is that it took several days, 2, 3, sometimes 4 days for the lab result to come back, because the driver, maybe the driver will leave tomorrow, and then for some reason it just took time. It doesn't take that long, maybe 3, 4, 5 hours to do the PCR test. I don't know, maybe it had to be confirmed and repeated. I don't know why it took so long to get the results back. But the problem is, meanwhile, you have lots of people that come in to the testing center who don't have Ebola, but they have the same symptoms: vomiting, diarrhea, fever. But then they're exposed to the same. Everybody's body fluids are everywhere. There's 3 buckets, one for each of different kind of body fluid. And if you're really sick, I couldn't. If I was really sick with typhoid, I couldn't always put all my body fluids in the right bucket or in any bucket, frankly. And also when you're really sick and dehydrated, confused, you try and sit on the bucket for your diarrhea. It's dangerous, I think. So there's fluids, and they weren't able to be cleaned up nearly as well as was able to be done later in October in Monrovia at the Doctors Without Borders Hospital. So what that means is that people were potentially exposed to the virus and infected with the virus in the hospital, which breaks, of course, the first rule of medicine: do no harm. And when I realized that, it was very, very, very disconcerting. And the Spanish doctor took me aside and she said, I had the same sudden realization, long before you got here. So, you just have to decide, are you going to stay or are you going to go? And so, of course, I'm going to stay. So one thing that we did is work with the Ministry of Health. I really try to do that wherever I go as much as possible during outbreaks. And so the Sierra Leone Ministry of Health and later the Liberian Ministry of Health. So here in August, work with the Ministry of Health, the chief nurse, to do training on personal protective equipment, Ebola-specific personal protective equipment. That's what I like to call it, Ebola PPE, because it's different than most other personal protective equipment, different than SARS and different than MERS, different than bird flu, different than pandemic flu. And so we were able to train a lot of people in the morning, and then there'd be another shift in the afternoon, or a group of people. And a lot of the people that came, they're all healthcare workers. A lot of them are nurses, because there really aren't that many doctors in Sierra Leone or Liberia. And a lot of the nurses had already been taking care of patients in the east, in Connaught or Kowloon. So why are they coming all the way across the country? It's a whole day trip, especially from Kowloon to have training from us. And us, where's my experience? So I dressed once in full PPE in a SARS hospital on a weekend when I was covering. I went to see a patient on a ventilator. That's where I learned that it's important to have somebody whose full-time job is to help you get dressed properly and then help you to get undressed out of your PPE safely. And for me, I adopted that from 2003 in the Toronto Scarborough General Hospital. And I was saying on anybody that would listen in July on radio interviews, Dr. Fauci and I were on the Diane Ream show and elsewhere, that's what we should have, a safety officer, I call it, or somebody that's full-time job is to make sure you put on the PPE correctly and take off the PPE correctly. So in Monrovia, it's just a picture of there's a whole separate tent that's just for putting on your PPE correctly, and people that help you, it's their full-time job to help you put on this is yellow, MSF uses yellow PPE, and other groups use white PPE. And that's the way it should be for safety. It's safety, safety, safety. But remember, 830 healthcare workers in West Africa infected, 500 dead. So right before I left at the end of August, I decided to write out 18 problems on one piece of paper, and I didn't show them all here, but just one piece. This is one page. 18 problems and 18 solutions, because nobody wants to hear about problems without solutions. And I learned that by talking to senior people in the Ministry of Health. And I talked to anybody and everybody that I could talk with. Data Nabarro from the United Nations, Casey Fukuda from World Health Organization, Tom Frieden, the head of the US CDC, the Minister of Health, pictured here in red, of Sierra Leone, the country director for Doctors Without Borders in Sierra Leone at the time, Lorenzo, and then several people who were in charge of doctors, MDs, who were in charge of treatment protocols for patients. And so I had a number of what I consider very serious problems. And I always remember one of the head doctors for the Ministry of Health in Sierra Leone said to me, you're listing these problems, but I don't want to hear about problems. I want to hear about solutions. So then I said, okay, well, these are some solutions. We don't have gloves. We didn't have gloves that were proper. They come up to your wrist and then they fall off or fall down. So you take a sharp object and you jab it through your PPE, and then you put your thumb through the PPE, like my shirt here. I put my thumb through it, and that would keep my wrist covered because the gloves didn't cover it. I wouldn't recommend that to anybody. But I was there, and it was like the Spanish doctor said, are you going to stay or are you going to leave? And really, that's what it comes down to. And okay, then the answer is clear. But it's not without some risk. And so I wouldn't recommend it to anybody else, but for me, it was an acceptable risk. Anyway, many other problems. You can't, nobody comes to draw the blood gets drawn, but there's nobody to drive it to the lab. The lab results take days to come back. There's power outages in the lab, so you need extra generators. So these are some of the reasons it would take days for the lab results to come back. Fortunately, by the end of August, there was a laboratory that could do the diagnostic test, a laboratory from South Africa. And I was so happy. I called up the head guy in charge of the lab and invited him to come over, invited him for dinner, invited him to whatever. He wants some money, anything. And he's like, okay, calm down. He's like, I said, do you understand how much good you're doing? Because now we get the blood drawn and it gets across town. It wasn't next door. That'd be ideal. I wanted the lab right next to our unit at Connaught Hospital. That's not going to happen. But across town in Freetown. And then they run the test twice a day. He said, we're here to help the patients. It's like, wow. It's so wonderful. So it made a huge difference. So the Spanish doctor and I, Dr. Marta Lato, said, okay, new rule, nobody stays 24 hours. Ideally, nobody stays 12 hours. So if you come in negative, the risk of getting infected is less if you're there for 12 hours or 24 hours rather than 72 or 96 hours. This is all I'm going to say. It was August, health minister, who got replaced soon after this, and the doctor from Doctors Without Borders, he was on the plane out of the country the same day I was, the end of August. No treatment center for Ebola in the capital until pretty recently. So I came back in September, no quarantine. The media was interested in calling, and normally I'm scared to death of the media for all these years. But now I'm still scared, but not to death. I was just scared. But I had something I wanted to say and about how bad things were and how we need to do things differently and better and quicker. And so I was glad to talk with anybody and everybody, the media, the BBC, the print media, anybody. And then I was very happy to be accepted to work with Doctors Without Borders. They say your first assignment, I've never worked with them before. The first assignment cannot be Ebola. It's too, I don't know what. It's whatever. It's Ebola. And fortunately, they called me and said I'm accepted when I was still in Freetown. And I said, oh, well, if I can't do Ebola, then I'll just stay here in Freetown. And I was actually just paying my own way, staying in the Radisson Hotel. That's another story, but it was worth it to me to pay my own way and stay there and work in Connaught Hospital. And they said, oh, you're already working in an Ebola hospital? In that case, you're accepted. I said, great, then I'll just stay in Sierra Leone and I'll go to the MSF hospital in the eastern part in Kowloon. Great, this is great. So happy. I don't need to come back to the DC and there's no students. Everything's good. So excited for about 3 seconds, maybe 2 seconds. And then the person, this is from Belgium, which is the MSF headquarters for the Ebola sponsor, it was. She says, wait. I said you can have your first assignment in Ebola, but don't get carried away. You're not telling us where you're going to be assigned. We're telling you, and we need you in Monrovia. We need bodies in Monrovia. We need healthcare workers in Monrovia. And she was right. That was the epicenter. That's where patients were being turned away at the gate, which I'm so glad I wasn't there having to do that because I don't think I could have recovered from it. I really admire people that did it because you had to do it, and some were very traumatized. And I know that because they came back when I was there in October after being there in August. Very traumatized. And that's all I'll say. So this is the entrance. Had mattresses on the tents, bottom of the tents, 180 of them. That was the capacity when I got there October 3rd. There were 135 or 6 patients. My team was, these are some of my team, almost all Liberian nurses and physician assistants and nurses aides, no doctors. And there were also nurses from Uganda, from Australia, from Brazil, and from Sweden and Italy that rotated through MSF, Doctors Without Borders nurses. And they worked in shifts, everybody worked in shifts, so patients were cared for 24 hours a day, 7 days a week. But there were only 3 doctors. So I was responsible for working with my team in 4 tents, and then a doctor from South Africa, another 4 tents, and then a doctor from Germany, and then they rotated from different countries. So this was the entrance. And all we did was work. MSF, very strict rules, which, I like it. I grew up in the military. Ebola, you should have strict rules, and they should be enforced. And if you break the rules, you pay the consequences. So, for example, there's rule no physical contact, none at all, outside. So basically, it's you work all day, you work all night, or in the evening, then you go home and you eat, and they have meetings, and then you go to sleep in your own room. You never shake hands, you never touch skin, nothing, 0. 2 young people broke that rule one night, and they were on the next plane out, gone. They didn't have Ebola, but it's the rule's there for a reason. So safety, safety, safety is a very important culture of safety in Doctors Without Borders. The personal protective equipment was much, much better than we had in Sierra Leone. Sierra Leone, what I had, exposed forehead, cheeks, gloves that didn't work, couldn't be washed down. There was nobody to wash us down. It was just the Spanish doctor and I. We sort of were each other's protectors. We they say buddies, but I say you should be protectors, because you're not buddies, you're protectors. That's what matters. You're not friends. You're protecting each other's lives. But it's not, it's not optimal. It wasn't optimal. So after 7 days, I basically had a branch point where I felt like I can't really do this anymore. I can't stay here anymore because it was so awful. So many patients were dying every day and night. So what am I doing? Again, we had no ability to measure tests, potassium, which becomes very, very life-threatening low when you have vomiting and diarrhea. Plus, it was very hot there in the tents. They were small tents. It was very hot. So patients would lose a lot of fluid through the sweat. So most patients are dying just because they're vomiting. Shouldn't say just. They're dying because of the dehydration and the shock because of vomiting and diarrhea. But now you add on a third way to lose fluid and electrolytes through the sweat. So what are the options? You can't say, I can't do it. Well, okay, so what does that mean? Well, it means either get on the plane and leave, or somehow make it tolerable, make it better somehow, even if you're just fooling yourself. Okay, so it's clear, this is one of those 3 o'clock in the morning decisions. Like, okay, I can't leave. Okay, so that's not an option anymore. So stay. So how are you going to make it better? So it basically came to me on 11th of October, I arrived on the 3rd, to make this simple 4 steps to help our patients survive Ebola. This is what I gave to the healthcare workers I was working with. And we hired an artist from Monrovia, and he made these color drawings. And it's really very straightforward. And I can just pass it around, but without spending too much time on it. It's basically the stages at which the patients were. They were too weak to sit up. Ebola gives you a profound weakness for some reason. It's possible. It doesn't. We're not sure why, but I can imagine likely hypotheses. So weak, you're just laying on your face or your back. So you clearly can't, and you're just making stool and you're vomiting and you're sweating and you're dying. So that's not acceptable. So what are we going to do about it? There's no IV fluid. It's possible. So you have to be able to drink. Well, if you're vomiting all the time, you can't drink. Okay? So you have to give medicines to stop the vomiting. So we started doing that around the clock. And medicines to control the diarrhea. These are fairly strong medicines that in the States, you wouldn't give them around the clock. Okay. But this is Ebola. And there's no opportunity for intravenous fluid. So that's what we started doing, and that worked. It worked to stop people vomiting so that you could then try to save their lives by giving them enough oral rehydration solution, salt solution, ORFs. It has potassium, sodium, and glucose, sugar, and water. And but still, you can't drink if you're on your back or you're on your stomach. And you're confused. It also makes you confused, Ebola, unfortunately. So then you have to help the patient sit up and help them drink. And you help them drink from the side, so if and when they, and sometimes they do, of course, just spit back what they start to drink or they vomit. And if it's right on you, there's some risk involved. So just do it from the side. Help them drink from the side. Slowly, and then a little bit more, and then a little bit more. But you can't do very much because you're only supposed to spend 45 minutes in the morning and 45 minutes in the afternoon in your personal protective equipment. This is the MSF rule. And then you had to come out because you sweat so much that your boots are full of sweat. You're walking in it. It feels like you're walking in a pond. Your hood, your face, your mask starts filling up with your own sweat. Sweat somehow got out of my sleeves routinely. I don't know how. We used to even tape up the sleeves. I don't know how. Once I scared a patient, I felt really badly about it because I always would approach the patient and say, are you having running stomach or are you having vomiting? And, oh yeah, so we're back the webinar. So not for any of the patients that I took care of, except for 2 women who are pregnant, who just were assigned to my tent. I haven't delivered a baby since medical school, but they passed away, as did the fetus in both cases, a 14-year-old and a 21-year-old. But that there was an exception made for no IVs for women who are pregnant with Ebola.
Was the reason just lacking the resources?
Yeah, so it's hard for me there were concerns that we didn't have enough healthcare providers to put in IVs in everybody, all the patients. And then you can't just put in the IV like here and then have it connected to a pump that automatically puts in, like, basically you have to stand there and squeeze the bag and have the fluid go in, and then patients are confused. So sometimes they're going to pull out the IV and then there's going to be blood with the virus everywhere. And, there are a number of reasons expressed. You can probably tell I'm not answering the question because I felt differently about it. Again, I felt like as bad as the situation is, in any given situation, either you leave or you make it better. And you got to decide how to make it better. And the standard of care may not be, well, it's not anything maybe you've ever seen before or been part of before or you really want to be part of, but it's you stay or you leave. And if you stay, you got to make it better. So there are things that, maybe could have been, but that was, I was the physician, but I worked under other people who were supervisors, physicians, one of whom had been there in August. And they said, nope, this is what we're doing, this is what we're not doing. And there are implications if you break those rules.
IV fluid is definitely in the standard of care here.
Yes, absolutely. Absolutely. And I think at some time when soon after I left, there were decreasing number of their patients. So when I got there, I'm eventually responsible for 46 patients with my whole team out of the 135 or so. 45 minutes, 46 patients. It's really not good math for the patients. But the number of patients declined quickly throughout, by the end of October into early November. So then IVs were possible I heard after I left. But when I left, there were 19 patients in the entire hospital. When I got there was 135. So an event, I think it actually closed in January. The drug trial that was started there closed because there weren't enough patients. So thank God for that. Okay, let me just move on. So one thing I realized, so there's a series of things that I realized that always, once I realized them, I really was upset that I didn't realize them sooner and took the same action sooner. But so one thing I realized was that the tents are searing hot. And so I'd encourage patients to get out of the tent. Like I said, in stage 3 or step 3, there in step 4, the patients are out of the tents, pretty much able to take care of themselves. So what about patients who are too sick to get up, too sick to crawl, too sick to get out of the tents? It's not acceptable. That's, you have to realize it's just if something's not acceptable, then you have to figure out a way to fix it. So if children can't get out of the tents, pick them up and carry them out of the tents. This was a 5-year-old who I thought was going to die every day for several days. And then I felt very guilty because I realized I was thinking he's going to die. His sister who was in the mattress next to her died, and parents are dead. And if you're a child and you don't have somebody that's strong to take care of you, who's strong enough recovering in the tent with you to help you to drink and take your medicine. So I instituted this other policy of directly observed therapy. We do it for tuberculosis. The patient you have to see them taking their medicine. Directly observed therapy for Ebola. Well, meaning the medicine to stop the vomiting and diarrhea. There's no antiviral drug, but it's directly observed therapy for the medicines that we treat for malaria, for typhoid. We get lots of medicines for fever. Make sure the patients take their medicine. And if they don't take it, then put it in their mouth. There's some risk involved. If they bite you, yes, but nobody got bitten while I was there, or that I ever heard about. So pick up the child and get out of the tent. And then the adults, 2 or 3 of us, help the adult get out of the tent. So by 9:30, 10 o'clock in the morning, when it gets really hot, patients have to be out of the tents. These are the tents, you can't really see them. This is the open courtyard. These are the 4 tents our team worked with. The other 4 tents over here, central courtyard. These are the chairs. We have people sit. Over here, you see a later picture. We created like a little children's ward or pediatric ward because children play with children. All these obvious things. I'm a parent. I needed to think faster and more. It's not creative. It's just the obvious things. So I'd say the most important thing that we did to help help patients survive Ebola, which was our number one goal. So I decided, they say it's case fatality rate 90%, 70%, 50%. It's just not acceptable. You can't do it. You can't live with that. You can't live with that. So basically, what we did was came up with a concept that was so obvious, and that was some people were already doing, but it wasn't formulated or wasn't codified or whatever. It's basically asked the stronger or strongest patients who are totally recovered, but the virus is still in their blood, so they can't leave. They're not considered a survivor. So I call them pre-survivors. They're outside the tents, walking around, looking good, smiling, asking for extra batteries, new batteries for the radio, because you turn up the radio, let's sing and dance and out in the open courtyard. It's like, okay, guys, you were in the tents on your back about to die 10 days ago. How about you go back in the tents and help the people in the tents? Because why? They're there 24 hours a day, 7 days a week. I go in for 45 minutes. Okay, so if I stay 90 minutes in the morning, 90 in the afternoon, it's still not enough. Right? But these people are, strong, and they're incredibly motivated to help the patients who were like them just 10 days earlier. And I think that this was the most important change that resulted in more patients surviving. And so we made these signs, and again, the Liberian artist, made more signs. This is survivors coming back home and being embraced into the community, which was the hope, but it didn't always happen. There's a lot of stigma involved with patients surviving and then trying to go back, be reintegrated into their community. In fact, there was stigma against the healthcare workers who worked there just because they worked there. So putting it together, there's the 4 steps. And so I put up these posters anywhere and everywhere in our main nursing tents and in the patient tents. The 4 steps, and the stronger helping the weaker to eat and drink so that more people survive Ebola and can go home and be with their loved ones. And that was it. And I hope you can't read this because it has names, so I'm not going to leave any copy of the slides here. But basically what we did was, this is the list of survivors. So we had 74 survivors between October the 8th and November the 13th. 70 are listed here. And then after I left, 4 more that I knew that I admitted survived, including some that were very, very sick, who had bleeding, a lot of bleeding, who were confused, who had hiccups, who basically, you shouldn't give up on anybody with Ebola, because all these so-called bad prognostic signs, people survive. So I'm going to go through a little bit faster now, mostly pictures because the time is late. So someone at Doctors Without Borders, Médecins Sans Frontières, MSF, in the beginning of October, right when we arrived, our team from the training in Belgium had this brilliant idea to create a wall we called the Survivors Wall. So if people survived, then they were offered the opportunity to put their hand in paint, the color of their choice, and then they put their handprint on the wall. And then if they wanted their name on the wall, somebody would put their name on the wall. Some people didn't want their name on the wall. And that was fine too. I don't know anybody that didn't want their handprint on the wall who's a survivor. And we had a formal ceremony of celebration when people survived. And it was just the most rewarding thing that I've ever been involved with in medicine and since 1979. A lot of children started to survive. But again, if you don't have someone to help you as a child, you're going to die. And then I realized that's true for adults too. So that's when we said the stronger have to help the weaker. And they did. And then some people who had survived in September came back for like reunions. And then also MSF started hiring people, small numbers, initially 7, then 11 survivors to come back and to work full time, especially with children who needed so much, attention and care and fluids around the clock. So it's just a wonderful thing. Survivors and nurses at the wall, the nurses, nurses' aides, physician assistants became, as I thought, it's just an incredible thing. You feel like, patients survive Ebola. It was always hot there. So this is just what we wore around. And you always went in scrubs underneath your PPE and then changed out. And I only had 6 pairs of socks a day, 3 in the morning, 3 in the afternoon, because you'd wear 2 in because you get so much of your sweat that you'd macerate your toes. And then if you got any cuts, so I'd shave at night in case I had nicked myself so it would heal by the morning. If you have any cuts or anything in your fingers, on your face, on your toes, and MSF finds out, you're not allowed to take care of patients until it heals. So, and nobody wanted to miss any day. And then there were a few nights. That's another story I won't go into. But you work some nights. You wake all night long. And I thought I'd have trouble staying awake because it's been a long time since I've worked in a hospital all night long. No problem. The problem is sleeping in the morning. You're wide awake all night long. No problem. We had volunteers from Australia, Europe, USA, Uganda. Everybody worked together. This was a discharge protocol. It's a celebration for everybody, you know. And we gave toy animals, stuffed animals to the children, and lots of a bag full of clean clothes, new clothes, clean clothes, and food. Peanut butter like food was very popular there. I used to eat it sometimes at night. And then the mental health team was incredibly important in the care of the patients. The gentleman in the blue on the right and the lady on the blue and the white on the left are the senior people in the mental health team. They saw patients every day. They took care of all the planning for discharge. I said, I want you to talk with me every day about what you learned about the patients you've seen that are in the tents 1 through 4. We had a patient who was 10 years old who was an artist. The nurse from Italy gave him a sketch pad or whatever we call it, and some colored pencils. Every day he drew pictures, new pictures. And he would come up close to the nurse's tent and he'd zoom in with their cell phone camera, and not the best quality, but there it is. And at the end, he had, I don't know, a dozen of these pictures, but of course they had to be burned. Nothing comes out of the hot zone. Everything gets burned. And so I said, well, I'll just use my cell phone, take pictures, and take it back to the MSF headquarters, and somebody printed them out, and then enlarged them, and then laminated them. And so when this young boy came out, got discharged, survived, we gave him the food and the clothes and all of his pictures, laminated and enlarged. And MSF liked the story, and they posted on their MSF United Kingdom UK website. This is the children's ward. So children, you know, they feed one another, they play with one another, they buoy one another's spirits, and they help each other to survive. It's always a joyful day surviving Ebola with the survivor's wall in the background. And again, the healthcare workers are part of that celebration. And honestly, for me, the children surviving was an incredibly momentous emotional experience. This was after a baby called Ben, after he was survived, he was discharged, and part of the ceremony is to shake hands with the person to show that it's okay now to have physical contact when they're discharged. And in this case, of course, the baby's, 15 months old or less than, I can't remember, but very young, couldn't walk, and also it really strengthens our own resilience, the healthcare workers' resilience. So pretty soon, by the time I left, there were 4 panels to the survivor's wall, and I hope that there were many more after November 14th when I left. This is a picture of Salome Karwa. She worked she survived. She was hospitalized and survived at the hospital here in Monrovia. And she was one of the first 7 volunteers to come back to work as survivors. Mostly she worked with the children. And our first day there, doctors and nurses came in from Belgium. It was their first day. We were all in the same tent. We didn't know who each other were. And we just said, well, hello, how are you? Who are you? And it was really wonderful to see her and other 6 colleagues who were survivors working with patients. And at the end, I got to work again with the Ministry of Health, this time in Liberia instead of Sierra Leone. We had all these multi-NGO meetings to standardize clinical and research guidelines that I was fortunate to be able to participate with. And so, again, we're back to where we are today, which is what's next. Well, Ebola's not gone. MERS is not gone. There's more avian flus. One of them could mutate, or some brand new one could show up that's like H1N1 out of Mexico that surprised everybody in 2009. Plague in Madagascar seemed to be a big problem, according to Director General Margaret Chan in January. Yesterday, she posted a message on WHO saying it's starting to come down, the plague epidemic, and including in the capital of Madagascar. And Marburg, the twin brother of Ebola, could show up again. But I think if we're prepared for Ebola, we're prepared for Marburg. So my last slide is an advertisement, and I have some flyers that if anybody's interested as you leave, you're welcome to take one. So again, trying to build on the theme of talk is good, but action's better. So we organized a big symposium September 23rd on Ebola at the Georgetown School for Foreign Service. This one's going to be a Georgetown, more in the medical campus area, called it Ebola and Beyond in Our One Health World. If anyone's interested, you can RSVP, and this is the same page as the slide you're seeing here, to that queen at yhq@georgetown.edu. Questions about content, I'm glad to try to answer. This is a collaboration that we've just started with a Smithsonian institution. Last July, before going to Sierra Leone, I met with the Smithsonian along with one of the graduate students from Georgetown and proposed that Smithsonian, that we work together and create a big major exhibit. will take 2 years to come to pass, so 2016 or 17. But we met and talked every month except when I was away. Then we'd connect by phone. And in December, the senior leadership at the Smithsonian agreed for the to have this exhibit on global emerging infectious diseases and basically in the One Health world. They really like the idea of the One Health perspective that I proposed to them. And obviously they have lots of scientists that work in this field. Probably maybe some of you are here now, but others I've met. Been fortunate to meet, like Suzanne Murray from the Smithsonian, from the National Zoo, and many others. And so we're having a symposium, and you all are invited. So thank you very much for your time, and I'm really sorry that it's gone so long, so I don't know if there's time for many questions, but I'd love to take some. I have 8:24, so it's quite late. Yes, sir.
I have several questions, so I can go last. Anyway, so, okay, well, in short, if you, first question is, for an individual thinking about wanting to volunteer,
yes,
and then for a group, what would be your key take-home messages, or what would be your lessons learned? So I, as an individual, want to go over there and help out, or then we, as an NGO, or as the military, wants to go and help out. So what are some key lessons learned that we need to keep in mind?
Yeah. So as an individual, that's right. I wanted to get over there as soon as I could, but how? Normally as far as I just got on a plane and went to Hong Kong, finished. But Ebola, you can't do that. You need to train PPE. You need to go with an organization. So now, if you want to go
Assuming
now,
you get there, what if you happen to just get there? Then what would you say to that individual? So what are you going to do? So that leads into my second question. The resources are very constrained. And I read one article.
In country?
Yes.
Yeah.
And so what actually are you, and if MSF is limiting you to 45 minutes a day in the morning and at night, and when you're doing that, you don't have IVs, you don't have diagnostic equipment, you don't have this, you don't have that. Right. When you're taking care of patients, what actually are you doing?
You're saving their lives. That's why I
like how? Where you just help them drink and eat?
But you say just, and that's what I would have said. But it's not just. It's the life-saving treatment. I don't care if there's not an antiviral. I mean, there's not. I wish there was. But my point is the 74 patients, and I didn't say this because I didn't keep a list of every patient who died. I started to, and it broke me. I couldn't do it. Okay. But at the end, I asked the person who kept track of all the patients who lived and died, how many died. And we had twice as many people that lived as died, which is still a horrendously large number of people who died, but it's much better than the case fatality rate. It's much better. So I guess, I'm sorry if I didn't make it more clear, or I did make it clear. By stopping the vomiting and stopping the diarrhea with specific treatments, by having physical contact with the patients. For me, that was very important because that's part of being a healthcare provider. And also I want to lead by example. I mean, there's a lot of fear, understandable, on the part of other healthcare providers. You don't want to have contact. You give the pills in a plastic bag to the patient. You say, open the bag, take the pills. You're on your back. You're so weak you can't open the bag. Or you spill your pills. You got to have directly observed therapy. You have to put, it's your job. So every patient, I went up and talked with them. It was a standardized thing. Are you having diarrhea? No. Are you having running stomach? Diarrhea, that's not a word. Are you having running stomach? Are you having vomiting? And it was all one motion. I'm asking this as I'm helping to lift the patient up with a colleague, Sierra Leone colleague, and then we're giving their rehydration. That's life-saving treatment. And it drives me absolutely crazy. Now I'm going off script. It drives me absolutely crazy for any organization or any individual to say that Ebola is not a doctor's disease. It really makes me very, very, very upset. You don't say that about MERS. You don't say that about SARS.
Why do they say that?
Yeah, why do they say that? Yeah. Yeah, there's no justifiable reason in my view. Yeah, so I'm sorry, I probably should go to one other question. I'm glad to chat with you.
Go ahead.
Okay, sorry. Yes, ma'am.
What can you tell us about what we know about the humoral immunity?
So you have all these survivors. How do you know they're really immune? Okay, so at the bare minimum, you should be able to measure, quantify antibody, and maybe characterize it. Is it neutralizing or non-neutralizing? To me, that's an imperative. So I wrote a protocol, a GHOST protocol, to do that for the Ministry of Health. That's why I wanted to go there. I had 2 protocols that I wanted to write. That was one. The other was for post-exposure prophylaxis, because we had a nurse who got stuck with a needle, another nurse who fell down and gashed her palm. So what do we know about humoral immunity? So anyway, so that, to my knowledge, that still hasn't happened. They haven't measured antibody. Is antibody more important than T cells? Is it important at all? I think we're not entirely sure, but yesterday morning there was a very nice talk given at the American Society of Microbiology Biodefense meeting in DC by Dr. Nancy Sullivan for the NIH, and she presented the whole history of immunology and Ebola, and as best we know it, particularly in animals, and in terms of vaccine development. And what I think she concluded, what I took away from it, was that humoral immunity is important, but T-cell immunity is probably more important. That's the long, short answer. So, yes, ma'am. Yes.
Just struck me as what you're saying, that when you give people a hug at the end, that's the portion where you actually touch the patients.
Oh, when what? When what?
Like at the end where you were like hugging them in the goodbye ceremony, that was the portion where you actually physically touch the patient. Without PPE. Like just looking at you with PPE the entire time, where I guess they can't see you.
So it hit me really hard the first week. People were dying, and finally had a family of 3 people, 1 child, and her parents who survived. I didn't think they would survive. The father, first one of the parents looked like he or she was going to survive. Then the other one, then the one parent was helping the other parent, and I was like, okay, but what about the child? But they were too weak. It was unrealistic of me. It was wrong of me to expect the parents to help save the child. I needed to have gone to a different adult who was well enough, a different adult who was well enough to help the child until the parents are strong enough then to help their own child. Because of course they want to help their own child. Of course they feel terribly guilty if they have somebody like me coming around in my PPE saying, you're not taking care of your child. Anyway, so in the end, it was a wonderful thing. All 3 of them survived. They come out through that. You have to get a shower. You leave everything behind. You get fresh clothes. And they come out, and I'm so happy. I'm standing there beaming away, and they're like just looking beyond me. They didn't know me. Because I'm a white guy, but I had still, goggles, you got PPE. You never see my skin. You just see my, around the white part of my eyes or face, whatever. So after that, first of all, it's about the patients, not about me. But honestly, I needed it's because the patients were surviving that I was able to stay. That was it. And it became the central goal. So after that, we had this open, I'm showing you that open courtyard area. So I'm standing here with no PPE. And so I made a point of every time that once the patients got out of the tent, I say, hi, Joseph, how are you today? Sally, how are you today? Hey, I'm Dr. Dan. So you write your name, Dan, on your hood, but so what? Except then they see the name, and then you say, all right, I'm Dan, or how are you? And then they know you. And it was wonderful. But it's so strange not to have physical contact. But honestly, being dressed in PPE and being able to, you have to get down, and I can't bend over so well anymore. I got to get down like this. But then you're kneeling in the virus. Don't fool yourself. But either you trust your training, you trust your equipment, or you don't. And it took me days, dressing twice a day, and then one day it just became second nature. And I knew that I was safe, and so and then I made a point of trying to lead by example, which is have physical contact with the patient. That's part of some primitive beneficial effect of healthcare providers and patients. I believe that, I always have, and I always will. So why am I not demonstrating that, leading by example? And then everybody's doing it. Some people are doing it before, but not everybody's doing it. It was such a wonderful feeling. So, sorry, Jimmy, share?
Yes, can you talk about any long-term strategies that were discussed about strengthening the healthcare system? And then another question that I have is that in the beginning you talked about how the healthcare system shut down and then people were dying due to endemic diseases. What were you seeing when you left the country? Because we talked so much about the Ebola treatment facilities, but were there treatment available to treat people that were experiencing malaria, pregnancy complications, those types of things?
So I think it was a matter of the most important thing is to come up with solutions, even if they're not standard solutions or they're not optimal solutions. Something good is better than nothing. Nothing is bad. Not everything is bad. That's nothing. You have to do something that's good. So Doctors Without Borders and other groups started doing mass treatment for malaria. So that's for patients in the community. They get up at 3:30 in the morning. This wasn't what everybody had to do 100% what you're doing. You meet at night for dinner, and so they'd wake up at 3:30. They go out 4:30 to West Point, the huge slum, or to other places in Monrovia, and they give malaria treatment to everybody because malaria is much more common than Ebola. Plus, if you have a fever and vomiting, then you could be Ebola. But if it's malaria and you get it treated, then it goes away. You don't need to come to Ebola treatment center, et cetera. I'm trying to make it sound nice. So that was a positive thing. Still, so many almost all regular hospitals and clinics were closed, and the healthcare providers who were working outside of Ebola units didn't have Ebola PPE, and they didn't have anybody full-time to wash you down, make sure you're dressed properly. So it's very risky for them to provide care. Sometimes a person has malaria, but they also have Ebola. Sometimes a woman has complicated pregnancy, but she also has Ebola. Maybe that's why she has hemorrhage. Maybe it's not. And so there was these really bad things I really don't want to talk about too much, but it's really hard. If you had a complicated pregnancy, you're likely to die, more likely than otherwise, because you couldn't get care. So all that was in transition. It was so wonderful to see the number of cases going down over the 6 weeks after Monrovia, and they're trying, the Ministry of Health, and then lots of people, China came in, Cuba came in, the U.S. Public Health Service, the German Red Cross, trying to restore some non-Ebola as well as Ebola. Certainly, the focus on Ebola treatment has been non-Ebola care, and it has improved. I don't know how much it's improved. I'm hoping to be able to find out when I go back in March. There's a question here. So. Okay, this man was here.
I was trying to ask you, as you alluded to, there's a copious amount of body fluid
Yes.
and waste. And so could you speak to how you handle the cleanup and the waste?
Yeah. So I'll just say from Liberia, because the answer there is easy and it's a good answer. Doctors Without Borders does a fabulous job, I think, in terms of the culture of safety and the implementation of the action to make it safe. So like I was saying, I felt totally safe working there during the day and when I had to work all night, all the time. It's the best feeling in the world, because then you can do what you're supposed to do, which is be a healthcare provider, have contact with the patients, help them directly observe therapy of their meds, help them drink life-saving fluids. So MSF has teams of people that are hygienists, that what they do is they go and they clean up the fluids. And what they did, you ask them, they say, it was just amazing sense of camaraderie. You'd say, and these are people from all over the world, from Iran, from Pakistan, from Brazil, from Australia. You'd say, look, we have to clean our hands in between our gloves, in between each patient. Why? Because it's the same virus, but there's bacteria and other viruses we don't transmit, have nosocomial infections in the Ebola tents, for God's sake. And we don't have time. You don't have time to go and wash your hands at the front of the tent where there's this big bucket. You don't have time. So what's the solution? Well, nobody's doing it. What's the solution? The solution is get the hygienists to come with their special bleach backpacks, if you will, and their sprayer devices. And you see the patient, you're having diarrhea, you're having vomiting. Okay, sit up. Okay, drink from the side. Okay, thank you. Wash my hands. Well, I don't have time. So the sprayer is there. They spray your hands down. You go to the next patient. Are you having a runny stomach? Are you having vomiting? It worked. And they were willing to do it. They have other full-time, and they have other things. Every time you'd say we need that vomit cleaned up right now. It was not right now. They just, okay, we'll do it. Somebody died. There's a dead body team. It's not burial team because there was mandatory cremation. Mandatory cremation. Should be a crematory near the airports. And so it was a dead body team. And dead body team came day or night. They came and they took care of the body. Yes, sir.
If you had laboratory-free ability to triage patients or diagnose patients, that would be helpful in such settings. And to that end, there's a study going to be published out of Conakry that's going to say myalgia and difficulty, quote-unquote, difficulty breathing is significantly significantly associated with mortality. What do you think about that? And what is difficulty breathing? What's you say there's runny stomach, or what does that
so
mean?
myalgia, I don't know. I mean, that just means muscle pain, right? And everybody has muscle pain. No, I'm just saying I don't buy that. So I'll look at the paper, but I don't buy that. I mean, how do you tell myalgia from muscle weakness? I mean, I see how they define it, but I'm not convinced at all. I'm very skeptical with that. But difficulty breathing, I'd say that's a bad prognostic sign. It's unusual. The virus doesn't, as far as you know, it doesn't. It could be that if you got IV fluids in you've got fluids in your lung. Could be that, but that was never a problem with our patients.
How often was that done?
It was none of my patients got IV fluid, so almost none of them had trouble breathing. But you get trouble breathing if you now have bacteria in your blood. You have sepsis because the bowel's perforated. Because Ebola is mostly an intestinal disease. It's not hemorrhage. Less than 3% had hemorrhage, and those who bled from the gums, from the stool, from the vomit, some of them still lived. So they're not dying because they're bleeding, but you get small perforations in the intestine, and the bacteria that live in our intestine get out into blood, and you get bacteremia, sepsis, or the medical term is, and that can cause you to breathe fast and because you get acidotic, and then so that's a real bad sign. So we gave impaired broad spectrum antibiotics that would treat for typhoid and for gram-negative bowel flora, not for gram-positive enterococcus. So I think probably trouble breathing.
How did you do that? Orally?
Yeah. Oh yeah, no IM. You can't give intramuscular. Can't give intramuscular. It happened one time during the night, and that's when the nurse got stuck. The patient was seizing, and couldn't stop him seizing. You'd have to give parenteral medicines because you're seizing. You can't give oral medicines. So it was a desperate act, and I understand it, but the nurse got stuck. But thank God she didn't get infected. I don't know how. So there's a big discussion about some post-exposure prophylaxis, experimental thing that a whole other story. That's why I wrote this ghost protocol afterwards, because I was really bothered by that experience. She was offered this, not by me, but by somebody else, experimental treatment, and she declined. She goes, "No, I'm going to rely on Jesus." She didn't get infected. I'm just saying that as a fact. I'm not an interpretation. But it was infected. She had Ebola blood injected from the patient, went straight from the patient's arm or buttocks, wherever medicine was beginning to stop the seizures, into her arm.
And she was tested positive?
No. She never tested positive. Sorry, she did not get infected with Ebola.
So did the doctors get regular? I mean, the doctors told me there were limited amount of physicians, but did the staff get tested?
No, not unless you had a reason to be tested. And if you have a reason to be tested, you're on the plane back to Belgium. No. But again, there are 830 West Africa, and the U.S. Public Health Service had a 25-bed hospital they opened near the airport, air-conditioned laboratories, available, done. First patient they had from us, a healthcare worker, another one, not one of ours, but a healthcare worker got admitted to our hospital. Second patient, third patient. And the first patient, I always remember, they sent back the lab results. They said the potassium was too low to measure, couldn't measure it. Too low to measure. But others were not that low. And then if you develop kidney failure, which occasionally happens, then potassium is very high. And if you give potassium, like you would for most patients to help save their lives with Ebola, you could kill them. So you really need to be able to measure that. It's not because the technology doesn't exist that the tests weren't available. Was there one other? Yes, ma'am. Yes, sir, you've had your hand up too, but go ahead, yes, ma'am.
How is the culture changing in these high Ebola countries? Are the greetings changing? Are you seeing behavior to one another being impacted?
So it certainly was during in October, November, September. So there's much less physical contact, and that was the message that came out. One of the messages, and my understanding is that, that in these countries in West Africa, it's more of a culture of physical contact. Greetings or farewells or whatever. And so that was a huge change. But now my understanding is it's going back to normal, if you will, now that the number of patients has gone down so much in Liberia, particularly, but elsewhere.
What's the barrier of culture? Are they used to touching to say goodbye to bodies? Was that part of the content?
Yes, I never went to a burial, but I talked with people regularly from MSF who did. One of the people on the cover of Time magazine, Ella, she went to lots of burials in Guinea and Sierra Leone and in Liberia. And yes, my understanding is that it's not at all like the burials that we have. There's a lot of physical contact, and also the burial process can go on for quite some time, even sometimes more than a day. So there's one more question. I'm sorry, you had your hand up a long time ago, and then you probably should stop because it's quite late.
Yeah, I've got to do this for 1 second. First of all, I'd like to congratulate you for being on the World Hero. You took 100 steps.
Thank you.
You're one of those folks that took 100 steps and asked, what can I do? And that is major significance, and I think affects everybody in here. In terms of could you spend 30 seconds a little bit on your symposium, and here's the core question to you as you have a symposium and you try to explore with others. Just in this town, in the last 2 weeks, about $300,000 have been raised in a free card to a guy who said, I can't get to work because I don't have time. And social media can turn. We have got more supply and more capability, and it is distant from the delivery end. And so you are on a very technical delivery end, absolutely screaming for resource. And there's all this resource to come to. Is that anywhere in your symposium thoughts about how you might try to do this?
Forgive me, are you referring to? I don't understand. You're not talking about getting vehicles or ambulances in Freetown when we didn't have any to drive the blood to Connaught. No, you asked.
You talked about 50 technical problems in the last hour and a half.
Yeah.
In terms of what you had to do, what you were doing without, what you had to do to make do with it.
Yeah.
The fact that you didn't have a lab, you didn't have a car, you couldn't put blood on a sample on a bicycle. And yet, we can move 115,000 flights around this country in less than 12 hours. So wait a minute, folks, we've got supply and we've got demand, and the bridge is missing.
Yes, it's about implementation or logistics or operations, and it's very hard for me to talk about. I'm really so discouraged and disillusioned. I called friends. I mentioned all these people's names. I went up to them in the Radisson Hotel. There's only one hotel in Freetown. It's great. So all these people come from the WHO, CDC. I don't know them, and I'm not on their level. But you know what? I go and talk to them directly, face to face. It's MSF has some phrase, témoignage or witness, or it's witnessing. I want them to know what's happening. I want them to come to the hospital tomorrow and put on the PPE. It's not very safe PPE. And I told them that. They didn't come in. Okay. But they came and looked from the outside. Okay. But how do you, I mean, I couldn't get gloves. I called people, high-ranking people, high, powerful people, some of whom were either here or come here at other times. And they really wanted to help. Everybody had the best intentions. But at the end, do you get the petrol for the car? Do you get the gloves that fit? Do you get a hood instead of having your skin exposed? Do you get IVs? Why can't we measure potassium when it can be measured in the U.S. Public Health Service lab that's only for 25 healthcare workers? What about all those other hospitals that the U.S. government built? There's no air conditioning. There's no laboratories.
Right. So just a thought for you. Talk to some of the top executives in FedEx, and you'd be astonished what you get as a response. Invite them to your symposium. They'll come.
All right, if they can land and if they could have landed, then if I knew them, I would have called them. Just fill up the plane with the gloves and the mask and the hood and the visors if they could do it.
It's a multi-billion-dollar company on delivery of goods and services. Just a thought to you.
I'd do anything to talk to anybody. And most I'm disillusioned and discouraged about myself that I couldn't make it happen. I'm old. I've met a lot of people over the years. It's good people who want to do the right thing, but it didn't happen. So intentions are fine, but in the end, it's either the action happens or it doesn't. And if it doesn't, so lessons learned. I don't even like to talk about that phrase anymore because it's the only way you know a lesson's been learned if you've implemented the action to prove that the lesson's been learned.
Pharma didn't want to help you.
I really don't know people in pharma, and it's a dangerous time, a dangerous place. And there's only one airline still flying, the Royal Air Maroc through Casablanca. Even Belgium, the Brussels airline stopped for a while, then they started again. But we all stopped. I don't speak the language. I don't know those people, and couldn't make happen what needed to happen. So one last thing, just another terrible anecdote is, so what about these children that get diagnosed? What about that 4-year-old that I mentioned? Remember, there's no treatment center. So where did that 4-year-old go? To Connaught, 4 or 5 hours away. If the road's good, if there's enough petrol. But what about the little babies who can't sit up? There's no car seats in these ambulances that we really wouldn't consider an ambulance. So we had to send the first baby, 1-year-old. Parents are dead. And who's going to take care of the baby? Baby needs to be held, right? But who's going to hold the baby? And so we made what I called baby Moses baskets. So they went to the Spanish doctor sent somebody out into the market, and they bought these baskets, and they filled them up with some kind of a soft material, and put the baby in the basket. And there was another patient who was so sick. The patients died in the car going to Connaught from Freetown with Ebola. Imagine you're so sick and vomiting, and then you put in a vehicle and you drive 4 hours, 5 hours to get in at midnight. Some patients are dead when they open the door. So there was an adult who said, okay, I'll watch the baby in the basket. That's what we did. But what was the choice? What was the alternative? Have the baby die in our testing center? There was no options, So you do the best you can. You make a baby Moses basket. Okay, thank you so much for all the time. Sorry I've gone on so long.